Sneha madam join aayinu.
I think we can wait for 5 more minutes because only 32 participants are there.
Yes madam. And we can start and sit.
Good. Shall we start? Hello, am I audible?
Yes, Dr. Kripa. Yes, yes.
Yeah,
Yes,
yeah.
Neha, I think you can.
Explain the
Okay,
clear
so-
manner to the patient and the family. Patients are educated.
Hello. Good evening, everyone. May I request all the participants to kindly mute themselves?
And now mute ಮಾಡ್ತಾ ಇದ್ದೀನಿ. ಸ್ನೇಹ ಮೇಡಮ್ ನೀವು ಅನ್ಮ್ಯೂಟ್ ಮಾಡ್ಕೊಳ್ಳಿ.
One second, ಮಾಡ್ತಾ ಇದ್ದೀನಿ. Am I audible now?
Yes ma'am. Others I have muted others.
Yes, yes, yes. Thank you so much. So, a very warm welcome to this IAMM Master.
Yes ma'am. ಅನ್ಮ್ಯೂಟ್ ಮಾಡ್ಕೋಬೇಕು ಮೇಡಮ್.
I don't know why it is. Am I audible now?
Yes ma'am. Yes ma'am.
It's going into mute. I don't know why.
ಜಸ್ಟ್
So-
ನನ್ನ ಕಡೆಯಿಂದ ಆಗಿದ್ದೆ ಅದು.
Oh, howda, sorry. Okay, so we all, I mean, most of you know Dr. Raksha Bhat. She is a very well-known microbiologist working at Manipal Hospital, Millers Road, Bengaluru. She completed her MBBS from MS Ramaiah and MD in microbiology from Kasturba Medical College. And right from her PG days, she has been really, good in her field. So she was awarded the best outgoing postgraduate students during her PG days, and was also awarded IMM National Conference Microcon 2007 Ananta Krishna Endowment Award. And in addition to her MD in microbiology degree, she has a postgraduate diploma in medical law and ethics from NLSIU. She also holds a postgraduate diploma from Symbiosis Institute in Hospital and Health and Management. She's also certified infection control from CBIC and also from APIC. She's a fellow of Royal Society of Public Health. She's a FAMER fellow. So she has, many credits, as you can see. With more than 11 years of experience in clinical microbiology, infection prevention and control, diagnosis of infectious diseases, AMR, hospital and lab accreditation, quality management system. She also is a certified internal lead auditor for clinical laboratories as per ISO 15189-2022, and also NABH assessor for entry level certification, and also a certified CAHO, ACE, CSST, and EndoSafe auditor. She has about 13 publications to her credit. She's a reviewer of IJMM and JMM, and she has presented many oral and posters in international forum as well as in national forum, and won many awards as well. Just to give a few examples, top five, he was one among the top five finalists in Innovation Academy at ICPIC 2023, among top 10 at ICPIC 2025, held in Geneva. And she was recently awarded top abstract in AI. I forgot to mention she has a certification course in AI as well. So she was awarded the top abstract in AI in diagnostics by European Society of Clinical Microbiology in 2024 in Barcelona. So with such a rich CV and a rich experience, I welcome Dr. Raksha Bhat to share her experience and thoughts with us. So Dr. Raksha, welcome once again on behalf of IAMM-KC, and the stage is all yours.
Thank you, Dr. Sneha, for that warm introduction. And it's really welcoming. Am I audible to all of you?
Yes, you are.
Am I audible? Yeah. So, it's a pleasure to be a part of IMM Karnataka chapter, and this is my first PG master class. When Dr. Satyanarayana invited me, I was really happy because when I was choosing the topic, I wanted to choose something which is really close to my heart and what I've been practicing for the last 11 years, all thanks to my mentors at Kasturba Medical College, Mangalore. Just let me know if my slides are visible. I'll just start sharing right now, right away. Is it in full screen mode right now?
Yes.
Okay. So the topic that I have chosen for today for the next 40 minutes or so, we'll be discussing on clinical microbiology by the bedside, thinking beyond the culture plates. This seems like a very, something which we are to practice or do we do really in practice. It's a introspective question that I always think about, and it's actually challenging, and what we want to inculcate in our postgraduate students, and probably a bit of interest for our undergraduates to choose clinical microbiology as their specialization. That is the intent of this topic being chosen. So the overview of my talk today will be microbiology as a clinical decision support tool. How do we interpret reports in patient context? What are the common lab and clinical opportunities learned through cases? Reports that we can use for rational antibiotic action, rapid tests, point of care tests, and AI that we can use in real time care, and focusing on clinician microbiologist partnership. We all might have seen this symbol long ago. In 1933, the Medical Council of India was formed. And recently, 5 years ago, it became the National Medical Commission, right? All of you agree? Now, this is a microbiology report. All of you can see the sensitivity here. And this is another report the resistance patterns here. So microbes also are evolving, so are our reports, isn't it? Now let's take a poll. Let's go to something which I all want you to go to. Go to mentimeter.com if you have your phones with you. I'm just going to full screen mode. Let me know if you're able to do this. Go to menti.com. Type this code 45519221. Are you all able to do? Am I audible?
You're
Hello?
audible. You're audible,
Yeah.
Dr. Raksha. You can just
Yeah.
repeat the code once again.
Yeah, 45519221. I'm sorry, this has about only 50 as a limit. So there are 70 participants I can see. I can see the responses coming. So the question says, in the traditional medical curriculum, microbiology is classified as, you can choose one option, preclinical, paraclinical, clinical, paraclinical in theory, but clinical in practice. We'll just spare about 30 seconds to 45 seconds on this and see what's the response that general crowd of, I presume that most of us are microbiologists here in this audience, right? So the code is 45519221. Go to menti.com and just choose this. There's nothing right or wrong here. You can just choose. 11 of you have responded, 12 so far. I can see 8 out of 13 still choosing. We'll just stop after like say 15-20 seconds. Are you able to choose one option?
Yes, yes.
Are you able to view the screen as well? I've shared the screen, yeah. So basically what we are seeing here is amongst the responses, although we have started here, 5 of us are saying it's a paraclinical subject. One still feels preclinical, one feels clinical. 4 of us feel it's paraclinical in theory, clinical in practice. So I'll just stop here. It's just for us to brood over things. So I'll go back to the presentation now. Yeah, so basically there is a confusion, right? Traditionally, we have been telling microbiology is a paraclinical subject. All of us still believe that. But how do we change this practice? So my question to all of us, including myself, what really stops us from evolving as a group of doctors who are specialized in MD microbiology? Something that we need to think about, right? I'll pause here for all of you to think. Now let's see what stops us. Microbiology has been classified as a paraclinical subject in Indian curriculum. All of us agree. It links basic science to clinical care. It focuses on infectious diseases diagnosis. We use microscopy, culture, serology, and molecular tests. We guide antimicrobial therapy. We support antimicrobial stewardship. We are central to infection prevention and control. And it aids in disease surveillance and outbreak control. And we emphasize now on laboratory interpretation. We are clinically vital, but we are thought to be lab centric. Right? What can change? What's the road forward? Is the below screen visible to you, or is this panel coming in the screen for you? Are you able to see the lines below?
There is a green tab which is clearly seen. Yeah.
Okay, nothing below that, no? Like the panel which I'm seeing here, you're not able to see, right?
No, no.
Okay, then okay. So, what do we need to evolve and involve as? We should involve ourselves in ward rounds and bedside discussions. This is the way forward. We should shift teaching to case-based, patient-centric learning, which we are currently doing with the CBME curriculum. We should add interpretative comments to microbiology reports. We should align culture and AST reporting with antimicrobial stewardship principles. We should use unit-specific antibiograms to guide bedside therapy. We should apply diagnostic stewardship to aid unnecessary testing. We should use rapid diagnostics and POCTs for early decision making. We should integrate AI and clinical decision support tools into reporting. We should encourage direct communication between clinicians and microbiologists. All sounds hunky-dory. Is it okay to do? Can we do? And we should evaluate success by the patient outcomes and not the test volumes. The long list of things that we need to do as clinical microbiologists, right? Now let's see the current status of our microbiology as such. 1 second. We are at the era of full automation now. Currently, we are somewhere in partial automation. If you see the picture here, you can see that this is where we are somewhere like, the machines, our machines say your bacteria alert, Vitec, if most of the labs that have, our machine answers the clinician's queries. We do analyze the data. We are somewhere in between here, right? With AI and all the machine learning, we are yet to reach this full automation. I don't think it's possible. The machine is going to replace the physicians, right? But even now, some of the labs are at no automation stage. But that doesn't mean that we are not doing a good job of clinical microbiology. We still can do. And I'm going to show you some cases where hardly any molecular or say any automation was used, and still we did a good job of having our clinical microbiology in the patient context. Now, this is something which I learned from Dr. Vandana and KMC Manipal. See, the need of our clinicians and patients. Full bale ele ಊಟ ಬೇಕು ನಮ್ಗೆ ಅಲ್ವಾ? ಐ ಹೋಪ್ ಕನ್ನಡ ಎಲ್ಲರಿಗೂ ಬರುತ್ತೆ ಇಲ್ಲಿ. ಸೊ ಊಟ ಬೇಕು ಎಲ್ಲರಿಗೂ ಚೆನ್ನಾಗಿ. So they want a diagnostic panel. But what's the want of our clinicians? It's like a big thali, would have had in one of these hotels where, on special occasions. But what is the supply that we give? ಈಗ ಪ್ರಸಾದ ಕೊಡ್ತಾರಲ್ಲ ಒಂದು ಚಿಕ್ಕ ಬೌಲಲ್ಲಿ ಕೋಸಂಬರಿ ಆ ತರ. So clinical microbiology is something like this right now. I found it very hilarious actually, but also something serious. What we need to know is there is a change, but there is change at various levels: technological change, legislational change. There is a pacing problem of change. What is happening in diagnostics, what is happening on the clinical side, what is happening in terms of policy. There is definitely a pacing problem that we all need to know. Now today let's sit and rethink together. Okay, let's see what is our profession as a clinical microbiologist. What can we do? I gave you a long list of things that we can do, right? What can we do in India to rethink clinical microbiology? Make ward rounds, ICU discussions, AMSP meetings, rounds not optional. It has to be compulsory. Emphasize on the outputs. Reward the clinical impact. Look at how much the report has affected the patient outcome. Emphasize on the de-escalation and not just the test volumes, the number of tests done in your lab. Strengthen the reporting aspect, not just reporting S, I, and R in the AST reports. It has to be contextual, and you should have interpretative comments in your reports. You should institutionalize AMSP and diagnostic stewardship. It should be a mandatory hospital function and not just a committee. You should train your clinicians and microbiologists together, not in silos, not having only a microbiologist CME or a physician CME. Have joint case review discussions. This should be inculcated in your postgraduate teaching. Then you should also adopt cascade and aware-based reporting nationally. This is not happening in many of the labs. We report a list of antibiotics, but there is no order to it, no sense to it. But it should be specific to specific infections like sepsis, UTI, VAP. All the cascade reporting has to be done. Use your rapid diagnostic wisely. I'll show you some cases where we have used the POCTs, but it was of no value, or rather helped us to rule out infections. And they should be in your interpretative frameworks. It should be within your clinical care pathways, and you should not do reflex ordering. You should also focus on the data. We are always looking at Western guidelines or articles which say VAP rate in this country was so much, SSI rate was so much. But what about the Indian data? We do have multicentric studies, but then again, they are still focused on, say, centers of excellence or few medical colleges. But the ground reality in tier 2 cities and other hospitals and the data are not captured. So you should build your local antibiograms, resistance maps, and you can use AI tools in the context of Indian epidemiology. And again, reforming the curriculum and assessment, I believe a lot is happening, although I'm not from the medical college background, but what I hear from peers is a lot that is happening in terms of CBME. And focus should be on communication also and skills in terms of soft skills, conveying things to the clinicians. How do you convince them to de escalate? How do you convince them to start an antibiotic? These kind of training also is of importance. And I believe this is a forum where we can think about advocating microbiology as a clinical specialty and not just as a lab service. And especially, this is just a request to the faculty out there. Think of giving a thesis to your students as a part of your MD microbiology with a clinical context. For example, if somebody is having, say, a ESBL rates in a tertiary care hospital, it is not going to be of much use now. You already know that a lot has been done and published. It has to be of clinical relevance. And it should affect the patient outcome. And thesis not for the sake of just doing a thesis. Now let's look at the microbiology clinical decision support system. What actually happens in the lab? We already know. You can look at the blue box here. You have a test that is being chosen once the patient comes to the doctor. You process the specimen, you do microscopy, direct examination, culture, incubation, you do the identification. It can be manual, it can be automated. Then you give the AST report, then the AST report reaches the clinician. So this is how we work, right? But the time duration here, it can vary from lab to lab depending upon your manpower. You can be a 9 to 5 lab, you can be a 24/7 lab. Now, this is a basic structure. Now, look at the orange box here. This is where you can intervene in terms of pre-analytical specimen collection. Also, you can look at the infection prevention, public health relevance of clinical microbiology, the direct communication and feedback that you give, the alerts that you give, the IT that you can use, the reference labs that you can use. There's a lot that you can do beyond the lab in terms of clinical microbiology. Now, in the same paper, I will share this reference with all of you later on. This was in 2017. This is titled as Antimicrobial Stewardship, How the Microbiology Laboratory Can Right the Ship. I really like the terminology that they have used in the this paper. They have said the captain of the diagnostic table is the microbiology lab. It's very interesting. I'll just read through the paragraph here. Just let's spend some few minutes reading these lines. It's very nice. Microbiology at sea, sailing into the sunset or returning to harbor. We really need to know where are we heading. Clinical microbiology seems at a crossroads. On the one hand, questions about the cost effectiveness and clinical utility of traditional microbiological methods and the pressure to cut costs have led to the outsourcing of many hospital microbiology labs to off-site commercial or centralized laboratories. Just today afternoon, one of our peers had called me, ma'am, they are telling me to reduce the cost of blood culture. They don't want to use two bottles, paired bottles. Anyway, you are not giving positives. No growths are there. No, can we use only one bottle? So these kind of things are happening. So thereby increasing the isolation of clinical microbiologists from their clinician colleagues. I really hated this term. We are isolated from the our clinician colleagues and consigning them to increasingly technical roles. So basically, we are inside the lab with technical roles. On the other, the crisis of antimicrobial resistance. A lot has been talked about antimicrobial resistance and the resultant need to optimize clinical infection management manifested by the widespread emergence of AMSP programs and the recent proliferation of innovative rapid diagnostic methods with their attendant uncertainties with respect to instrument selection, performance characteristics, deployment and workflow costs, interpretative guidance, and rapid technological turnover could boost the clinical relevance microbiologists to level unseen since the time of Koch and Pasteur. As clinicians, long immersed in the practice and teaching of ID and AMSP, we are certain that this distancing of microbiology laboratories has deprived bedside medicine of a critical source of a nuanced expertise, and we urge clinical microbiologists to seize emerging opportunities to reassert themselves. We need to reassert ourselves to our patient care. In part, this review is intended to offer a roadmap by which this can occur a part of AMSP program development. I'm sorry this was very long, but we really need to rethink on the way our career paths are growing. Do you all agree? There's a lot of that needs to be done as a community of clinical microbiology. But where do we start? It's a Pandora's box right now, right? But can we all do something? We can all be Christopher Columbus, right? He set sailing towards India, wanting to search a route to India, but he ended up finding the Americas. Were you all aware of this? So, what I'm trying to tell you is there's a lot that we need to do in our labs. Exploration is really the essence of human spirit, which was said by Frank Borman. He's a former NASA astronaut. So, let's see this picture now. Medical innovations, lot has been started since the 1670 with Antoine van Leeuwenhoek's microscope to the metagenomics that we are in now, right? We can have this, we cannot have this in our labs. It all depends on our setting. We can use the best of the technology and still do worse microbiology. That's what I believe. But we can use the least of the microbiology techniques with the less automation and still do a good job out of it. Now, this is something which we are all aware of, an antimicrobial infection prevention and diagnostic stewardship model. We have roles in all the three, right, as microbiologists. Now, I'm going to discuss few interesting cases which uh, in a day probably I would find happening through the day from morning till evening. I'm just highlighting few of them. And these are not your traditional clinical cases with, say, presenting his complaints, past history. This is with a microbiologist perspective. Okay. Now let's see case one. This is a case where gram stain smear teaches about specimen quality. We had a 56-year-old woman presenting with fever, cough, breathlessness, suggesting of community-acquired pneumonia. Her repeated sputum cultures were showing mixed flora. So the pulmonologist called me asking, how come you're giving mixed flora every time? She's coming with cough again and again since the past 3 weeks, and every time you're giving normal flora. So when he looked at the smear bag, it had abundant epithelial cells, very few pus cells, indicating poor specimen quality. So we went back to the ward, asked for a proper sputum collection. We realized that the sputum was not being collected properly. We guided the nursing staff how to collect the sample with deep cough sputum collection. And it showed lanceolate shaped diplococci. Now, traditionally, if I had to report, I would say gram-positive cocci in pairs, many pus cells, few epithelial cells, no fungal element seen. That's all. And if I'm not going to add any value to the report, then he's not going to use the gram stain. He or she is not going to use the gram stain. So, if you have to explain the report in depth, you would say capsulated, lanceolate shaped, suggestive of streptococcus pneumonia, and you would probably add an advice of antibiotic also and correlate with culture, right? And radiologically findings. So your gram stain by itself can add a value to antimicrobial stewardship and diagnostic stewardship. A good gram stain before you start your culture is a very important tool for stewardship. So the lesson learned in this was a gram stain can teach nurses and patients as much as it can guide antibiotics. Let's go to case 2. Now, this is another case, say probably about say 2 hours later. Ceftazidime, ivibactam, and astronam synergy test. Some of us are doing it in our labs right now. You can see the picture here. The astronam disc being placed next to the E strip, and you look for this clearance. Now, what happened here? It's a very interesting case. We had a critically ill patient in home ICU having a MBL producing Klebsiella pneumonia. It was in the urine, it was in the ET, it was in the blood. He recovered through sepsis. He was getting back to normal. But when he went back to the home ICU from our own ICU, we realized that he still needs to continue the Ceftavi Astronam treatment, and synergy therapy, synergy testing was not being done in a lab by that time, and it was just being given without the test being done. So I recommended my ICU doctors, you need to do the synergy, otherwise there's no point in giving. How do you know it's an NDM and OXA 48 producer? And the synergy test will only help you if Astronome is working for this patient. So the attender came to the lab. The daughter came to the lab asking, can you do this synergy test for my father? He's in the home ICU. So I had to sit with the attender, explain her about the Ceftavi and Astronome synergy. She literally broke down saying, I am running dry. I don't have finances to continue. If you're telling me the synergy is not going to work, I'm not going to buy the next dose of Astronam ceftazidime maybe Bactrim tomorrow. So this is something which I think an empathy factor which we microbiologists can develop in terms of antimicrobial stewardship. Playing a role in counseling patients is also an important factor, which I don't think we are doing currently. I know it's a gray area. We may say that it's the clinician's job, it's the pharmacist's job, but a day might come where we may have to do this more frequently. Now let's go to case 3. This is about meropenem. Meropenem isn't always meropenem. Confusing, right? So this was about prolonged infusion where he had a neurology patient. A neurology patient with sepsis grew a pathogen, which was again MDR Klebsiella kind of scenario. But what happened was meropenem's MIC was high. It was still sensitive. I think, if I remember, I think it was 4. And patient was not responding because we went down to the ward and saw what was the infusion being given. The nurse said over half an hour. The doctor looked at me, the clinician. Then I said, why don't you try it for a prolonged infusion of 24 hours with a loading dose initially to be given to maintain time over MIC, because it's a borderline MIC and patient responded within the next 48 hours. So rather than changing the meropenem to again a higher antibiotic of say Ceftavi and Astronam or say or any other thing that we wanted to use like a colistin, we changed the dosage of meropenem. So this is where the microbiologist with knowledge of pharmacy can intervene. So we used a prolonged infusion strategy to sustain plasma concentration above the MIC for a longer duration. So this was a PKPD aligned approach that we use for killing the bacteria and stabilizing the patient without escalating the antibiotic. You can still modify and play around with your antibiotics if you know the PKPD well. So if you see these 3 cases, what can you understand? There is DSP, that is your diagnostic stewardship. There is antimicrobial stewardship. There is infection control stewardship. There's a lot of overlap happening here amongst different stewardship initiatives that we need to take, right? There is overlapping areas of collaboration and action. Now, another case, same day it happened. Okay, so we had Stenotrophomonas maltophilia in our bronchoalveolar lavage samples. Suddenly, there was a cluster of 3 cases over a period of last 2-3 days. So instead of just sending emails and sending on WhatsApp to our clinicians, I went down to the pulmonology unit. I asked the pulmonology team, are you suspecting Stenotrophomonas maltophilia in these 3 patients? We sat down, we reviewed the 3 case files, we called the ICN, we called the bronchoscopy technician, we asked him how is he cleaning the bronchoscope. Then we realized he's not drying the bronchoscope. He's not keeping it for dry for as much duration it is supposed to be done, probably because of the case overload. So we didn't give any antibiotics to all these 3 patients. We retrained the technician again on the reprocessing part. We ensured that it dries properly. We actually even sent it to ETO once and saw that, that is not working for us because we have only one bronchoscope in our unit. So this multidisciplinary collaboration was necessary to talk and interact not just with the fellow clinician, but also with the technician, also with the CSSD, also the company person. So these are the areas where the microbiologist has to step out of the lab and talk to people. So the lesson was, see, some of the outbreaks are solved not by reporting, it is solved by walking around the hospital. And just a question to all of you: how long? How do you? Do you go around the campus or not just walking in terms of different departments, but interacting with your other fellow colleagues? Again, case 5. This was another case of a breast abscess. This was a lactating mother with recurrent breast abscesses. She's coming repeatedly with different cultures every time, growing E. coli, Pseudomonas, corns. every time a different report. And she had a very atypical clinical course, was not recovering with the antibiotic regimens that was being given. So the surgeon called me and said, can you come down and see this patient? And in fact, I went along with my pathologist and we did a punch biopsy for her, uh, sent it for AFP culture. And then what we found was Mycobacterium abscessus in that. And she recovered with treatment. So basically, what was happening here was every time a new culture was there, to believe it or not, the sample request form didn't have any detail. It just mentioned pus on the first time. Second time it came wound swab. Even the location of the pus was not mentioned. So until then, we were also clueless. Why are we reporting a different organism every time? Okay. This patient, in fact, came back to me with a box of big sweets telling you cured me, which nobody could do. I know we had to literally tell her that, this could have been avoided with the first swab or pus that was collected itself. So what I want to tell with this case is when your routine cultures fail and patients are not responding to the regimens, please look at other organisms. You have to think about other organisms which cause such infections. This is the last case. This was recently, last week. This is beyond the report when clinical context turns a contaminant into a diagnosis. This was last Sunday. We had a 38-week primigravida who did not recognize labor pain. Quite surprising, right? And she delivered at home. Her old grandmother said, no, it doesn't look like labor pain. The baby was brought in a wrapped towel. She was a booked case in our hospital. And the cord was cut using scissors. Okay, this happened on a Sunday. The baby developed early onset neonatal sepsis soon after admission. We sent a biofire panel. It came negative. But the next day, the Monday, the bottle flagged positive. The isolate from the bottle was identified as Streptococcus gallolyticus. Traditionally, if something was not written on the form, I would have missed this as a skin contaminant. But the fact that I spoke to the pediatrician and I knew that there was a history of using scissors for cutting the cord, there was a strong suspicion of these contaminants being pathogens. We looked at the PCT, we looked at the counts, we looked at the patient condition, and then we decided, okay, we are going to start vancomycin for this patient, and the baby responded well. So we insisted that we do the clinical correlation. We did the AST for this, and this was an unusual isolate. Traditionally, it would have been a contaminant, but in neonates, it can be a significant pathogen. So here we did use the molecular test. It costed us around 18,000 for the biofire, but it was all negative. The next day, the culture helped us in diagnosing the infection. So this is where your molecular test rules out and your culture, the gold standard, is something which helps you to diagnose the infection. So these are the 6 cases I just wanted to present briefly. So let's see what are the elephant in the room, probably in this Zoom meeting that we are. Reluctance, avoidance, awkwardness. We have taken up a paraclinical subject. Will the clinician recognize us? Denial, ignorance, diversion, silence. So, see, these are the things which we have to cross and reach out to our clinician colleagues and stand up to them next to the bedside. So these are the challenges in this paper that is mentioned in a very nice way. This paper is titled Optimizing IPC and AMSP in Bedside Discussion. This is a scoping review. I urge all of you to read through this paper. I'll share these articles later with you. What you see here is the focus is mainly on discussions and communications, which is under prioritized with your clinician colleagues, which we need to do. You need to have a multidisciplinary team input, get your pharmacists along with you, get your ICNs along with you, go to the wards, have structure and standardized contents, have formats, audit formats, have checklists. It could be manual, it could be automated, or it's just the way you stand and speak. So what I would like to tell is team learning is the process of aligning and developing the capacity of a team to create the results that your members desire. Your infection control team, your AMSP team, your microbiology team. You build on a discipline with a shared vision. If we want to do something through microbiology, each member of your team in your lab should be doing it. And it should be based on personal mastery. You should have the best of the technicians who are interested in patient care as much as you. So for talented teams can be only be made up of talented individuals. But is it so easy? First, we have to acknowledge ID diagnosis and AMSP is complex. It is not easy. You have to build the acumen over time, and it is a day-to-day process that you build. Patients have physiological changes. You have to localize the infection. You have to look at what investigations you would want to do with the minimal resources you have. You have to determine the severity. You have to initiate timely treatment. You have to review and refine. And this is complete teamwork. But there are some terminologies which we need to know before we start some test and we want to do some test, which is a pre-test probability. If I'm going to do this test, okay, what is the pre-test probability? It refers to the estimated probability of the disease before the test result is known, which depends on the local prevalence of various diseases for suspected infective syndromes. For example, say dengue or typhoid. Depending upon the season and the region, you can say this is a cause of AFI in our region. Likelihood ratio. It refers to the potential utility of a particular test to diagnose a disease. For example, blood culture we use in the first week of typhoid fever. If you want to do it in the third or fourth week, you may or may not get the pathogen, right? So what I want to tell is let's move together with the clinicians. It should not be behind the clinician, nor neither in the front of them. We have to move together. So let's see what all we can do in diagnostic stewardship. You can order the right test. You can help them to order the right test. You can help them to understand the test. You can talk about pre-test probabilities with them. In the pre-analytical stage, when you look at talking with the clinicians, you can look at specimen collection, preparing and transport. When you discuss with them, your terminology should be in this: the quality of sample, looking at contamination, what is the disease prevalence, looking at the risk factors, right? Now, coming to the analytical stage, we are all very good at this, right? You are interpreting results, choosing what test to, do, what to report. Probably we need to standardize in some way, but we all do something or the other in our labs, which I think we do a pretty fair, good job in each of the settings where we are working. I'm not going to talk about in depth because we have a lot of things already covered in terms of NABL or say your QCs or EQUAS. This is our bread and butter, right? Now, what can we do in the post-analytical phase? Cascade reporting, which is we all have been advocating since the last couple of years. Strategy of reporting AST in a stepwise pattern. We still are not doing in many of the hospitals. Second is your reflex testing, where you do a test only if a precedent test, like say urine analysis showing presence of inflammation, then you ask for a urine culture. Examples are like this: like you don't order a battery of tests at a time. You can suppress the results. Say you have multiple organisms growing and and the patient is not symptomatic, and you can always give it as a insignificant bacteria when the colony count is low. You can talk to the clinician and say, I'm not going to release this every pathogen that is grown in the plate. Fourth thing is framing. You can present the choice in terms of highlighting the positive or negative. For example, if you have a group B streptococcus in high vaginal swab, I'm not going to report the antibiotic susceptibility testing report because we know that it is a sensitive organism. It's not known to have resistance. Now, coming to the post-analytical state, you can look at how do you communicate the results. This is beyond the report that you print out. How do you integrate your microbiology with your clinical decision supports? You can have MDR alerts, you can have blood culture positive alerts. You can even comment on the antibiotics that you want to give, the dosages, the drug interactions. You can even do that. But this still requires a lot of LIS and IT support and a good ID support that you need to have in your setting. It may vary from place to place. The fourth part is your education, continuous education, not just updating ourselves, but updating about microbiology to our clinician peers. What are the new tests that you have in your lab? What are the new updated guidelines? It is not enough that only we know CLSI or ITSA. And if somebody calls you saying, why don't you, report this? We can't tell them, refer the ITSA guidelines. That's not how it works. We have to tell them what exactly it is saying and probably share the guidelines with them and tell this is what is given. I mean, probably that's the way we talk is what is important on how we update them about our guidelines. The interpretation of test results I've already told, and clinical practice should be based on evidence-based principles. Now, this is one study that I had presented in ITSA 2021. This is on correlate clinically, the use of interpretative comments. You can see here how the sample requisition forms completion improved over a period of say 3 years. Initially it was hardly 49%. Like, see, if you can see, it's almost improved to 95%. Means to say every TRF that we got almost had clinical data mentioned on it, because they knew that the interpretative comments were coming based on the data that they were giving. Now, the feedback was also taken from clinicians. They loved the accuracy, timeliness, relevance, usefulness of the report. So we can do these kind of short projects in our own institutes and see how the quality of the report is helping our clinicians. So basically, this is a book which I want to all of you to read, which is called The Nudge by Richard Thaler and Cass Sunstein. It basically tells you about the nudge effect. If you want to encourage an activity, make it easy. So it has to be easy for the clinicians. And AMSP or diagnostic stewardship is basically about behavioral interventions to guide decision. And it is through choice architecture while you maintain the autonomy of the prescriber, that is your clinicians. He or she is all right to start meropenem. But the de-escalation or continuing the meropenem should be done at 48 to 72 hours. And that nudge has to be coming from the microbiology lab. So this is another important paper of ITSA, a guide to utilization of the microbiology lab for diagnosis of infectious diseases, a 2018 update. This talks about 10 key highlights, which a microbiologist should do. Reject poor quality specimens. Microbiologists should clarify specimen issues with physicians responsibly. Avoid demanding reports of everything that grows. Minimize the background noise from commensal microbiota. Prefer actual tissue aspirates and fluids over swabs for specimens. Adhere to procedure manuals supported by evidence-based literature. Collect specimens before starting antibiotics. Perform susceptibility testing only on clinical significance isolates. Report microbiology test results that are accurate, significant, and clinically relevant. Allow the lab, see, this autonomy and freedom should be there. Allow the lab to set technical policy, fostering collaboration, and ensure accurate specimen labeling for reliable result interpretation. So these are the 10 key highlights mentioned in this paper. Now let's look at the RDTs which we currently have and talk about. A lot has been happening in this. Lot of biomarkers, WBC, ECR, ESR, CRP, lactate, PCT. All these are already there in the lab, but how well do we use this in the initial stage of identifying the infection? More so, I want you to pay attention to gram stain. Do we use gram stain as a rapid diagnostic test? Tell me how many of you do the gram stain on the same day the sample comes and the sample doesn't go to the fridge. So gram stain by itself is a rapid diagnostic test which you can use for stewardship. And of course, your molecular tests. So these are the FDA approved RDTs. I'm not going into the details of these list of panels which we already know of. A lot of things are happening in many of the labs with regards to biofire, Maldita, film array, everything we are using, right? But what is the aim of using this? Your targeted antimicrobial therapy, because of this RDT, should start right from day one. Instead of your traditional 3-day culture report. When you talk to a clinician, he'll say, oh, microbiology report. It takes 3 days to come. No. Your intervention should start right from day one. And this can be done along with your gram stain and culture itself if you're giving your provisional reports. You don't have to rely only on your molecular tests. This is another new concept that is coming up, point of care tests, where you don't have a lab at all. The entire equipment is within the critical care setting. It can be in the ICU or in the ER, chip-based technologies. You don't need a technician. You don't need a microbiologist. The nurse herself can do the test in the ER or critical care unit. There might be a time which will come when we will not have jobs also, right? With all these. So what is the implication in an Indian setting? Is it possible to say have POCs in every case? We are with less manpower, we have regulatory issues, inadequate infrastructure, and we also spoke about the communication gap. But there is an opportunity for us to use POCs. You have low turnaround time. It can give personalized diagnostics, early detection and proper planning. So what are the criteria to choose a POC? It should be affordable, sensitive, specific, user-friendly, rapid and robust. It should be equipment free and delivered to the needy. Now, you might be seeing a lot of POCs coming now. A lot of companies are coming to you. And of course, NABL has told all the POCTs are under the realm of the lab, right? We can look at having these POCs in our specific units for in terms of diagnostic stewardship and AMS. It really helps to have them. Now, let's talk about AI, where all AI can be used in the pre-analytics itself while ordering the lab tests. 70% of your errors can be reduced by reducing the manual work of entering the forms, choosing the sample, right? And again, analytics, here a lot of work needs to be done. Pathology, a lot of things have been done in terms of image analysis. We are still yet to do with terms of annotating your gram stains or your AFB smears. We can do some projects on these. I don't think microbiology, we are still working in India on these kind of things. We can use this on interpreting and decision mentoring based on the reports. And the post analytical part, you can use it on using customized reports specific to your patients. For example, I did a small project only on recurrent UTI, only on Klebsiella, and it gave an alert in our LIS for the clinician if the patient was coming back with a recurrent infection. So it used to give recurrent UTI MDR alert. So these kind of things you can do using different AI models. You can do a lot in terms of post analytics, helping the clinicians deciding whether to admit the patient, whether to start an antibiotic. So this is what I wanted to show. This is courtesy to Dr. Rajiv Somen. In one of the webinars he had shown microbiologists and clinicians. This is from Sholay. So coming back to our Karnataka. So have you seen this movie? Who is this? Vishnuvardhan and Ambarish. Have you heard this song? I hope I bring back some memories to all of you. So we microbiologists should be like this with our clinicians. So this is Dr. Abdul Kalam telling. Creativity is seeing the same thing but thinking differently. We all read culture plates. We all report. But what do we do with that? That is what I want all of you to think about. If you see this picture, this movie, Passengers, 110 million was spent on that. The Martian, 108 million was spent on that. Interstellar, 165 million was spent on the movie. Gravity, 100 million was spent. Avatar, 237 million was spent. Our Chandrayaan 3 in India, the actual moon mission, we spent 75 million. So it's not always about money. We may have the limited resources, but we still can do a fair job with what we have. Clinical microbiology is not about just automation and rapid tests. So look at your own labs, go back to your departments and see what is the low hanging fruit in your department, what can be done as a small step that you can take. You have to start, you may start small, but you have to start at some point of the time. So let's take another poll now at the end of this session. I want you to go back to the same Mentimeter. I'll just open it once again. So please open your Mentimeters once again. How would you like to classify clinical microbiology as? Am I audible? Are you able to see the question? Hello? Am I audible?
You're audible, ma'am.
Yeah. How would you like to classify clinical microbiology as? Diagnostic clinical microbiology, therapeutic interpretative clinical microbiology, preventive and surveillance clinical microbiology, or benchwork and bedside systems integrated clinical microbiology. There are 4 options. You can choose what you want to do. So just select what you want to do. So I can see 5 people have responded until now. I can see all of you choosing the fourth option, bench work and bedside, systems integrated clinical microbiology. Somebody wants to do therapeutic and interpretative clinical microbiology. Good. Okay, I'll just exit from this screen. So I can see that some of you at the end of the session have at least thought of having a systems integrated approach to microbiology. So this is what I wanted to share with all of you. Any questions I am happy to take from all of you. You can go through the chat box. You can contact me on email. Any cases that you want to discuss, I'm happy to discuss with you and have an integrated approach, irrespective of where we are coming from. I think at the end of the day, patient bedside is what a clinical microbiologist should have the best clinical judgment, is what I believe. So thank you to IAMM-KC for this opportunity. I think I would like to end here. We can take any questions in the chat box first. If someone can help me with the questions there, I'll be happy to take. I'll
Thank you,
stop
Dr.
sharing now.
Raksha. Yeah, yeah,
Thank
sure. Thank you. Thank you, Dr. Raksha, for that very, I would rather say motivating talk. I'm sure most of our young microbiologists will definitely think from bench to bedside. I think
Yes.
there are a couple of questions which were put up during the talk. So one such question I can see is IV antibiotics have side effects and they alter microbiomics. In critical patients with low prognosis, are they advised to limit any legal implication?
Yes. See, again, what I want to say is in our country, this is a gray area. When you go for, say, the job description of the microbiology, starting from how you want to define your intervention, you will have to be very clear in terms of documenting it. In my institution, what I have done is when we set up our AMSP committee, we gave a mandate that the microbiologist and the clinical pharmacist has the right to intervene, but the final judgment will be by the clinician. And it was an undertaking that all of us signed. So, what we have done, we have made a format for the clinical pharmacist, a format for the clinical microbiologist. We enter in our suggestion in that. This is advised, this is not advised, but the final decision is by the treating physician. Now, when you talk about microbiomics in these critical patients with low prognosis, what I understand is you get different sets of patients and it is complex. I showed you a slide where we had different interactions happening in terms of PKPD, side effects. It is case to case basis. And unless you talk to each other, you will not be able to decide what to give, what not to give. Many times we have discussed what not to give rather than what to give. Talking about legal implication, what I believe is as long as you document on your case sheet what you're intending to do, what you're not wanting to do, you are safe. But again, this is again an evolving specialty. I think in our country, in terms of the clinical microbiologist on rounds, is still a concept in growth. I think we'll have to build on these things. Probably we can take it up as an initiative by our own state chapters and see what we can do in terms of building our specialty like a clinical specialty. How
Yes.
to
Yes.
how to prove known contaminants and as pathogenic species.
Pathogens.
Yeah,
Yes.
see, now this is again an interesting question. And when you look at your own setting, what are the contaminants you usually expect? Probably, say, blood culture or a urine culture, or you say your sputum. You have your normal flora. If you know your normal flora, what are the common organisms that you know there? Like, say, your Streptococcus viridans, diphtheroids, your bacillus, say, your lactobacillus. Could be anything that you usually see as a part of the flora. You know that this is a contaminant. But what about the patient history? Is it an immunocompromised patient? Is there an indwelling device? Is the patient taken previous antibiotics? What has he come with? Unless you talk to your clinician, you can't rule out this contaminant whether it's a pathogen or not. Like, for example, the case that I spoke about, the last case, It was Streptococcus gallolyticus. We even have had coagulase negative staph cause valve related endocarditis and things like that. Unless you talk it out with the clinician and see the history is matching with the clinical picture, you can't really differentiate otherwise. And otherwise, you are going to just report everything that grows. There is no correlation with it. I can see Dr. Ashok Ratan sir posting post requirements have moved from assured to reassured and now rest assured. True, sir. Yeah. I think it is, only two questions, Dr. Sneha. I don't see any more questions there.
Yeah, if anybody wants to ask, they can unmute and ask them in the
Yes,
forum.
yes.
I have a couple of questions, Dr. Raksha.
Yes, Dr. Sneha.
Yeah, you mentioned about the pharmacist's role, even in the clinical decision support. It really helps. But though antimicrobial stewardship has been made mandatory, so to say, by even NMC, the recruitment of clinical pharmacists is not mandatory as such in medical colleges as of now. So, do
Okay.
you have a clinical pharmacist in your, hospital, and
Yeah,
how important do you think is the role of a clinical pharmacist?
I understand we come from different settings. I have one main pharmacist lead and six more. We are a 225 bedded setup. We have totally seven clinical pharmacists with us. So life is easy for me. It's not the same for others. What happens is, what we have designed is once the clinician starts the antibiotic, we have a pre-authorization form. Then we have monitoring, which is done by the microbiologist who authorizes the uh, high-end antibiotic. This is discussed with the pharmacist. We both go together and see the patient and write in the case file itself whether it is justified or not justified in the form. Then the nurse indents it. So the pharmacist goes back to the clinician on rounds, talks about drug interactions. For example, today we had one patient where we had stopped meropenem, teicoplanin, and doxycycline. Three were being given together, and the patient had nothing, no indication of these three antibiotics. So the pharmacist went and spoke to the clinician, and the clinician stopped. So I think that empowerment to your pharmacist is necessary. Whether NMC mandates it or another organization wants it or doesn't want it, I believe that having a trained clinical pharmacist is really something which all of us need, because as a microbiologist I may not understand the drug interactions and side effects. There's a lot to learn from them also. I have learned a lot from my pharmacist. So all this PKPD, the interactions, I think this is something which even the clinician may overlook. They contribute a lot to bedside decision making of choice of antibiotics. It's a must need at this hour, is what I feel.
Yes, yes, agree with you. Any other questions? I think there is a comment in the chat box, which says that, as you mentioned, contaminant grown second day in culture has to be proven using gold standards such as Cox postulates. So they just
Yes.
reiterate what we discussed.
Yes, we had got the same isolate in the second bottle also. So we had got isolated from the culture itself. And the baby responded to the antibiotic given. We had given vancomycin. So because there was history of using unsterile equipment to cut the umbilical cord, it matched the diagnosis. So yeah, so what I was trying to tell was we may rule out something with the molecular tests using a BCID panel saying, okay, nothing is there, but baby was in sepsis and all the counts were high, the PCT was high. So once we started the antibiotic on the patient on vancomycin, the baby responded to therapy. So it almost all the Cox postulates were covered, and the repeat another culture before we started vancomycin also grew strep galoleticus. We even did a CSF, but thankfully the baby didn't have meningitis. So yeah, we were happy that the baby was saved due to like some unsterile practice. A booked case, getting such a organism on culture was unheard of, especially in a tertiary hospital like ours. So that was something which was like, where we had to interact with the pediatrician to say, this is not a contaminant. This looks like something significant.
Yeah, there's another question in the chat box. They want to know what guidelines are you following in your hospital for antimicrobial stewardship?
See, we look at the antibiotic policy in terms of using our CLSI current M100 guidelines. We have used that for making our antibiotic policy revised as per the edition. We also look at our own local antibiogram. We change the antibiotic empirical advice based on the current antibiogram that we have. Currently, our MDR rates are high, and we even meropenem is being given as empiric many times. We are looking at all those things. You see, it is a dynamic thing. We look at the national treatment guidelines also. We look at various guidelines, but at the end of the day, what I want to tell you is, unless you sit with the clinician and discuss what is their specialty specific guidelines telling you, it cannot be one guideline that you're following. You have to make it custom made to your own setting. You might be a cardiology specific hospital, you might be a pediatric serving hospital. So what I follow in our unit is basically we have all super specialties. So all our unit specific guidelines are specific to the units. So I do allow the high end antibiotics in some of the units, like say nephro and ICUs. But the other units where it is not required, we still go with the first line and second line cephalosporins for treatment, and it's all very custom made. So it's not one guideline that we follow.
Yeah, actually, just to add to what Dr. Raksha said, even if you're working in a small hospital or even a PHC level kind of a setup where you can't or you don't have culture facility or you don't have antibiogram of your own, as was pointed out by Dr. Raksha, you can definitely rely upon the national treatment guidelines. Even the
Yeah,
recent 2.0 version has come. So you can definitely rely on that. And some, as we were discussing, start somewhere.
yeah. At least
I
what
think
I say is, if you want to start somewhere, start with your ICUs. If you want to start, just start with your ICU or probably a high footfall OPD. You can choose one of the OPDs and start.
Yeah, I can see two more questions. One is about the role of biofire in the
Biofire.
present scenario. And the second is to how do you prioritize organisms for further follow-up if multiple organisms are isolated from respiratory secretion?
So first question, what is the role of biofire in the present scenario? Biofire, not just one molecular test that I would want to talk about. Any multiplex PCR panel, if you want to include in your diagnostic care pathway, first look at your clinical care pathway. What kind of patients are you catering to? Are you looking at the sepsis panel, respiratory panel, GI panel? What panel are you looking for? How do you want to incorporate it in your clinical care pathway? What value is it adding to your patients? Can you make a panel of a battery of tests suggestion to your clinician where it can be incorporated in your diagnostical algorithm itself? First thing is the cost of the test. When traditionally when you say biofire or say any other molecular, everybody will be like, oh, we can't afford, our patients can't afford. That is not the point. I mean, if you really want to include it in your diagnostic algorithm, you can reduce the cost of it by talking about what you're ruling out as an infection. So you can use biofire or any other RDTs for that matter, even NGS you can use. It all depends on what policy that you want to have as a lab, diagnostic pathways that you want to make. What we are trying to do is, say you want to have a meningitis panel, you can have your cell count, cell type, everything together with your culture, with your BCI, meningitis panel, make it as a package. And once you rule out, the clinician is really happy that, okay, this is ruled out. It is not just about ruling in. So you can work around the cost and make it affordable. It is not that biofire has to be costly or any other molecular assay has to be costly. It can be worked out and it is possible. And understanding the pre-test probability, what I was talking about, is very important. And also, we microbiologists don't talk about finances. What are you going to achieve by using this test? What is the investing rate of return that you get out of this test? When
Yes,
can you
there
have
is
a
a yes, sorry to
uh,
interrupt. There is a question regarding finances. How many, in case somebody wants to start in their hospital,
mhm.
how many tests should be done per day or per week to break even?
break even. See, this is what I was trying to tell. Like, say, when you want to start something, you look at your patient footfall. Like, what cadre of patients are you looking at? Are you looking at neurology patients with meningitis? Are you looking at ICU care, sepsis patients? Are you looking at pediatric patients? What tests can be ordered in your setting? Say, on a day, if you, and the number of beds that you have, how many patients that you get in, all that matters. I think you can have a separate session on this. And what is the cost per test for you on that? And what is your turnaround time for that? And then what is the patient going to be treated with based on that report? If you can talk about these finances to your in charges, I think they'll be more than happy to invest in these kind of tests, because at the end of the day, microbiology is not just mere strains and cultures. You need to have these tests, as I already spoke about, evolving from microscopy to NGS. I think we need to understand how to pitch in for these things, especially when you're presenting this to your management. How do you break even is again, like, say in my setting, if I want to say I am yet to get the biofile in another 1 month, I probably might be getting in my setting. We have finally given a proposal and it's cleared. What I am expecting personally is at least 2 or 3 per day, and we are hoping to break even by at least a year. So I have given a strong proposal with an Excel sheet of showing how many are expected in the best case scenario, how many are expected in an average, how many are expected in the worst case, and by how many years can I get returns by investing in this. And it again depends whether you're buying it on rental or you're purchasing. I think that can be another session by itself for us microbiologists. We have not really learnt in our MD curriculum on how to invest or choose a analytical platform in our labs, right?
So 2 to 3 per day in a hospital of your size, according to you, will take a year to break
Yeah.
even.
It depends on how much you're pricing the test
Faster for a
also,
bigger
right?
hospital. Yes, yes.
Yeah.
Okay. So there was another question as we saw. Um,
How do you
how do you
prioritize
prioritize? Yeah. So could you please?
isolated from respiratory secretions? See, I was talking about the gram stain there. See, initially, even before the gram stain, you look at the macroscopy of the specimen. Is it sputum? Is it saliva? How do you accept it? What is your Bartlett scoring criteria? After you receive the sample, do you do the gram stain immediately? Do you report it within 4 to 6 hours? Based on that, are they starting anything, any antibiotic? Are they doing anything about the uh, choice of antibiotic? Then next day your culture grows something, right? You correlate the gram stain with your culture. So prioritizing multiple organisms. Okay. In your, what are you expecting in your respiratory secretion? Of course, there will be some flora, say your Streptococcus viridans, or say even for that matter, Moraxella, which is an upper respiratory pathogen, can be part of your flora. You are expecting pneumonia, H influenzae, or say your gram negatives like Klebsiella or others, like say if it's a nosocomial, you expect Pseudomonas, or it depends on what you're looking at. So prioritizing will be again a clinical acumen, a benchwork acumen that you have, looking at the plate, looking at the microscopy, looking at the clinical picture, what the clinician has written on the form. I think it all comes with the daily looking at your plates. I mean, you can't completely put it on technicians and say, you read the plates and write, and I will just authorize. So prioritization is by reading plates, is what I starting from seeing your samples to reading your smears and then reading your plates. I would like to summarize like that for the answer.
Yes, agree with you. So though there are guidelines, there are textbooks to guide you, you need to develop your own algorithm, right?
True.
Okay, so if there are no more questions, I think we would like to end the session. Thank you once again, Dr. Raksha, for that wonderful
Thank you,
talk.
Dr. Sneha. Thank you, everyone. It was nice.
And thank you all the participants for your active participation. Thank you.
Thank you.